Good morning. We are talking about bowel elimination today, and this is in your textbook in chapter 47. And this is Dr. Paula Stennett that is doing the voiceover for the PowerPoint today. So let's review the objectives for this lecture. First of all, it's always a good idea if you review your normal anatomy and physiology of the system that you are about to study, because in reviewing the normal, then you're prepared to look at the differences that occur and the abnormalities. So the second objective we'll look at is analyzing several factors that influence bowel elimination, and there are several of those that we'll be looking at. There are common problems that affect elimination and common nursing interventions that we do to promote and assist the client with normal bowel elimination. And even when it may not be so normal, there are things that we can do to help them with bowel elimination. We'll be looking at relevant nursing assessments and what you will be doing as far as assessing the abdomen and bowel elimination, characteristics of bowel movements, assessing the abdomen when there are lack of bowel movements, and then of course in your head to toe you will be doing that on each clinical. Select nursing diagnoses that are associated with altered bowel elimination. We'll be looking at some medicines that are used to treat constipation, some medicines that are used to treat diarrhea. Those are on our last slide, and you'll need to look those up. I would advise to go ahead and make some drug cards on these that would be helpful for you as well, to get a good understanding of the different types of things that we do use, because they're not just one size fits all. And of course, medications also are used to help with diarrhea, stools, not so much anymore, and we'll talk about that. We'll get back to that a little bit later. Get back to that slide. It advanced a little bit while we had it off. So naming the structures as you do your review of the normal A&P, you will should be able to do that. So just spend a little bit of time going down the esophagus into the gastric pouch, into the duodenum, the jejunum, the small bowel, looking at that, the place where the nutrients are absorbed, a very important part of the alimentary canal. Of course, the mouth is important in chewing, and the stomach's important in mixing and so forth. But also the large bowel is very important in elimination. So as we process our food, there are byproducts, and then elimination has to occur. So we can certainly appreciate that. We'll be looking at common problems in each location, particularly the colon, not so much the upper part of the alimentary canal today. And then we need to look at some preventive measures to help keep each of the structures healthy and free of disease. All right, just the picture of the alimentary canal there as you would see it in your anatomy book, and for a quick review of that. And then we have a cutaway, which includes the stomach, small bowel, large bowel, down to the rectum and anus, which of course the rectum is the final part of the large intestine, made up of folds, and within the folds you have veins that help control fecal content. And these veins can get all strained, when the patient is straining, these veins can get all distended, and that is the process by which hemorrhoids develop with large abdomens, which can occur during pregnancy, which can occur with other disease states in the abdomen, or simply with excessive weight gain. Okay, the anus is the canal that allows you to expel feces or gas, and of course you recall there are internal and external sphincters that help us to control elimination until we can get to a place where it is okay to defecate. So that being said, gives you the appreciation of continence, and the thing that may be present when there is incontinence. It can be a neurological event, it can be a structural event that has occurred, or injury in the anus or the rectum, or it can be a central nervous system condition that is allowing the incontinence to occur. So defecation is a normal act and normally is painless. Pain can become painful with fissures in the anus, can become painful with any kind of obstruction, can become painful if there are hemorrhoids, and that would be an actual obstruction as well. Okay, so let's look at some terms that you need to learn. You probably recall peristalsis from your A&P class, which is rhythmic contractions of the GI tract. Jump down to the next to the last one, gastrocolic reflex. So these are rhythmic contractions which occur following ingestion of food, and it's not unusual for the urge to defecate within a fairly short time after eating, and actually schedules can be developed that help make that happen, which for convenience. We learned some people don't like to go into public restrooms, and I don't guess anyone likes to, but some people are really resistant to that, not wanting to have bowel movement in a public place. Go back to the paralytic ileus, the second term there, loss of GI motility, and this is not unusual to happen. I mean, it's a common occurrence for it to happen after surgery, particularly if the patient's had manipulation of the bowel. So we're talking about abdominal procedures or procedures involving the retroperitoneal area of the abdomen, and where large amount of opioids, I say large amount, could be just relative for the individual. It might be small amounts for some that there would have slowing down of GI motility after opioids. And we think about other anesthesia. So the post-op period is a big time for this to happen. Also, trauma to the abdomen for any reason, and again, medications can cause the development of paralytic ileus. So it's not unusual in this situation for the patient to have nasogastric tubes and evacuation of the upper GI because of the lack of normal peristaltic activity and things being moved forward to be eliminated. Okay, let's look at melena, blood in the stool, and melanotic typically means a darker red color, and the higher the bleeding is, blood in the GI tract, the higher it is. By the time that it comes out, is eliminated, it will be very dark, the higher it is. So bright bleeding passed in the stool is typically from very low in the GI tract. And then there may be somewhere not too far up, several feet up in the large bowel, actual stools where there's lesions that bleed there, that stools will look kind of like a cranberry color. So varying colors of blood in the stool. What is the Valsalva maneuver? That's bearing down the typical activity that occurs with the urge to defecate. So there's some bearing down. And then the other term that's on the page here, fat in the stool, which is called steatorrhea. This occurs with pancreatic problems where the lack of the pancreatic juices are not adequate to break down the fat, so it is passed in the stool, look like globules in the water, oily, greasy-looking appearance to the commode water. And of course, if it passes in the bedpan, you may be able to see surface globules and that sort of thing. Let's look at factors influencing elimination. And of course, age, activity, diet, psychological factors, position during defecation, personal habits, pregnancy, pain, fluid intake or lack of, various medications, disease conditions, surgery and anesthesia, which we just talked about. And we just talked about medications such as the opioids. So we just kind of go backwards here, won't we? Of course, with pain, such as might occur with large painful hemorrhoids, the person would probably be reluctant to try to have a bowel movement when the urge hit. So that can also influence elimination. Psychological factors, like we mentioned a while ago, the holding of stool, because, well, we've had particularly in the younger age group, pediatric age group, children, once they get out and they attain bowel control, but there's children who have been known to, because they didn't want to stop their play or whatever they were doing, or they didn't want to go into that bathroom, that they would have accidents because they held the stool until they couldn't hold it any longer. And of course, with the withholding of stool, we'll be more apt to have a development of constipation as more water is absorbed from the stool in the large bowel. Activity or lack of activity can certainly produce decreasing motility of the gut. So exercise, activity, walking and that sort of thing, or even range of motion exercise in the bed helps to promote GI peristalsis. Okay, various disease conditions can influence elimination. We have diseases you'll be learning about as we move through the next few semesters, such as Crohn's disease, irritable bowel, ulcerative colitis. Those are not for today. These conditions which influence bowel elimination, and certainly, we'll be looking at that. Other neuromuscular diseases where there's poor innervation and a generalized weakness and laxity of the abdominal muscles as well as the gut muscles would contribute to the conditions that affect elimination. Fluid intake. So lack of fluid intake are the type of fluids that are being taken in, and the relative lack of just water for hydration can certainly affect elimination. And let me put you on hold again. The abdominal assessment. First of all, the abdomen requires exposure for the assessment to occur. Pulling back the sheet and the gown and being able to fully view the abdomen is important. We don't want to cause the client to feel exposed, so protect their modesty with the sheets or bedclothes right about the level of the hips to cover that area. And you may then proceed. The first order of assessment techniques is inspection, which simply means looking at the abdomen, looking at the contour, looking at symmetry, and so forth. So you want to make sure that you inspect first and then auscultate. The reason you don't auscultate or that you don't palpate before you auscultate is because of the touching the abdomen can alter the presence of the bowel sounds, so it can definitely affect those. So we want to listen, auscultate first, and you will auscultate in all four quadrants. You need to develop a technique of starting in, for instance, right lower quadrant, and auscultate there. You want to be able to hear bowel sounds, and if you do not hear bowel sounds, you continue to listen and have to actually be able to say there are no bowel sounds present. Then you would listen for a full 5 minutes, and proceeding to the right upper quadrant, then the left upper quadrant, and then the left lower quadrant. So in the event there are no bowel sounds heard, then you would have listened for a full 20 minutes, and you will be able to say unequivocally that you have actually auscultated fully, listening for bowel sounds, and that none were heard. So be sure you have your earpieces fitted well into your ears and have the room quiet. You will need to prepare whomever is in the room. If there's family or visitors, and you might want to ask the visitors to step out to protect the patient's modesty when you're exposing the abdomen, and also to reduce any extraneous noise, turn down any technology that's on to be able to adequately hear. And certainly you would need to explain that well, that you're just not arbitrarily doing that. And then you may lightly palpate. Particularly here is a good time to do a pain assessment if that hasn't already been done. First asking about any discomfort, and then having the client to actually point to the area of greatest concern, and additionally if does it radiate anywhere, and you may at that point ask them the character of the pain. Is it a crampy pain? Is it constant or intermittent? How long has it been going on? The intensity, if the client is able to respond coherently, we ask them give them the scale of 0 to 10, 0 being no pain at all, 10 the worst imaginable pain, and have them to try to place that on that numeric scale. Otherwise than that, we do have the other scales that we can use for patients that are not verbal or who are not cognitively intact. And so we look at the FLAC model and FACES scales. Okay, so our percussion is a technique that is not so much done by nursing, even with advanced nursing practice with today's technology. If there's a question about conditions, enlargements of organs, or other pathology going on there, they're getting scans and MRIs and so forth. Percussion was used in the past, particularly to outline solid organs such as the liver. We could determine if the liver was larger than it would normally be, then by percussion that we can tell where the borders are. And as we switch over, because it's like the drums, and when you get over a hollow area, it sounds different than what it is over a dense area, and you could play around with that if you wanted to with the think about a thigh, how that is a dull sound, and then over an area where there's more gaseous distension, you would get the more hollow sound. So, all right, so common problems with bowel elimination are constipation, development of impactions, fecal impactions, diarrhea, incontinence, bowel incontinence, flatulence, that's excessive gasiness, hemorrhoids, and ileus. So constipation, there's where too much water is absorbed from the stool, or there wasn't adequate water being taken in. The patient's dehydrated, and they end up with small, pebbly little stools and infrequent evacuation. Other causes are changes in diet or lack of fiber. They may have an increased intake of other constipating type foods. Lack of knowledge about regular bowel habits, and lack of water intake, as we've already said. What is an impaction? Well, this is where a constipated person becomes unable to relieve themselves or have a bowel movement. They're unable to expel the bowel movement. And this is oftentimes seen in debilitated patients who are not very active and who have gone on for several days without having a bowel movement. They may have some liquid stool seeping around it, so there may be a little continuous kind of expelling of liquid stool, but that hardened mass is actually obstructing from normal bowel elimination, and this can become a significant and serious problem. So removing the impaction will be done digitally. Typically, it can be very uncomfortable, so we want to be as gentle as possible with it. And we are concerned about stimulation of the vagal nerve anytime there's any going on with the rectal area, and that stimulation of the vagal nerve can cause bradycardia and syncopal episodes or passing out episodes. What is diarrhea? Frequent loose stools. Typically, they're gonna have over more than 4 per day before we actually have the diagnosis of diarrhea. So just 1 or 2 few loose watery stools does not is not true diarrhea. So causes, of course, are infections and things like viral infections, but it also can be bacterial infections such as C. diff, which can result after a person is treated with lots of antibiotics for various and sundry infections. And other things like food allergies and intolerances can cause diarrheal illnesses. Okay. Chemotherapy for treatment for cancers is another common thing that can cause diarrheal illness, because it gets the bacterial normal flora there out of balance, and just like with the taking of antibiotics for pneumonias and so forth, can do the same thing. But C. diff is something that can be, we put our patients in precautions when they have this, when we get a culture back on this patient, and we have to have them in contact precautions because of the high incidence of transmission of this from one person to the other. So hand hygiene with just the rubs is not adequate. Soap and water must be done after caring for these patients, and because of the actually the alcohol in the hand sanitizers will not eradicate it. Okay, so let's see, we did the incontinence, which is the involuntary passage of stool. It could be from impaired sphincter tone or function, or it can be from a spinal lesion, or even in the central nervous system that this happens. Incontinence typically happens as patients are expiring. They lose both control over urinary as well as bowel. Flatulence is excessive gas and passing of gas, and may have distension with it. And it's not unusual for the patient who have digestive disturbances such as gallbladder disease to have flatulence. Hemorrhoids are these are vessels in the gut, in the rectal area, and they can get obstructed and by intra-abdominal pressure, pregnancies, ascites, which is free fluid in the abdomen that results from liver disease, and different things like that, which can put a lot of pressure downward and cause these vessels to become much like distended veins in the legs, like varicosities. It's the same process of hemorrhoids, and these things can be quite painful. And even more so when they're attempting to have a bowel movement. Some of the common things that are used are sitz baths or warm water, and it could even have ice packs, intermittently with using that. And then, of course, the Anusol HC suppositories, hydrocortisone, and preparation H and things like that, which are helpful in relieving that. And sometimes surgery is actually required to get to evacuate a clotted hemorrhoid. What is an ileus? An ileus is where we actually have the loss of motility in the gut, and same thing as the paralytic ileus, as we were discussing earlier. Okay, so with constant oozing of stool or constant seepage of liquid stool, if there's not an impaction there, and it is a true diarrheal illness, is particularly in the acute care areas, critical cares, the patient may have a rectal tube that is placed to actually divert the liquid stool into a collection bag. And there's a caution with that, with placing the tube. Anytime there's a foreign body going into a body, we have to be very cautious with it. But there are little clips, balloons that are there to help control, just like on the Foley catheter, a seal, to give a seal and to help divert the fecal matter into the collection tube. Okay, so let's look at bowel diversions. So in the event that there are disease of the colon, and that could be anything from ulcerative colitis, diverticulitis, perforations, bowel perforations, could be something like Crohn's disease where a portion of the colon has to be removed. Then a diversion is made of the distal portion of that bowel is drawn out through the abdominal wall for the passage of the bowel movement. And sometimes this is temporary or reversible, and sometimes it may be, a permanent diversion. So it just depends on the situation, what has to heal before it's rehooked back up. And they make surgical ilioanal pouch type things to try to keep it to where it would be as normal as possible, where they wouldn't where actually can retain stool and not be incontinent. So it just depends on what part of the bowel has to be pulled out on the abdominal wall. If it's a large bowel or colon, it's called a colostomy. If it's actually they had to do a total colectomy, and what's left is the distal terminal ileum, then that is what's brought out to the abdominal wall. It's called an ileostomy. Okay, so there's some nursing considerations. You can actually pull up that on YouTube and watch that video. All right, let's see. Oh yes, assessing the stoma. Once the stoma is surgically created, we need to, the patient is going to be in the hospital probably for several days, and we need to assess the stoma color. It should normally be bright pink or a brick color, and if it changes to blue or brown or black, then that indicates circulation problems. It's a surgical emergency. The surgeon will have to do a revision. Okay. So monitoring the skin around the stoma is very important. Monitoring for any leakage. The client will have a ostomy device that is to collect the stool, because there's no there isn't any way initially that there can be any control. So it'll be just like the incontinent person. The effluent will come out, when the peristalsis brings it there. So there's no sphincter control. It's actually like we have with normal bowel movements. All right. So caring for the stoma, cleaning around it many times immediately post-op. They'll want us to just to use normal saline around it, clean the skin, and then replace a new device. And so in our kits that we get for ostomy supply kits, we have measuring devices, and this is simply like a sheet, like a cardstock sheet, and it has different, like centimeter diameter measuring devices. So we find the one that best fits around that stoma. Of course, the colostomies are going to have a larger stoma, ileostomy smaller. So we find the one that fits. We simply by placing it over the ostomy. And so there should be, very, very little we want to have it as good a fit. It can't be too tight, but very little, skin around that. It could, fairly snug around that. So then once you find the appropriate size, then it is drawn onto the adhesive portion, like with the Sharpie, and then we cut that out, and then to cut it to fit. And after the patient is cleansed and rinsed and dried, well, then the appliance is reapplied. Okay, so we teach the patient how to do that. It's one of the things. As soon as they are able, able to see what's going on, then they need to learn to do it, because they're going to have it at least for a while until they can have their reanastomosis. Okay. So, communication with this patient, the nurses want to have a very therapeutic approach. We want to show acceptance. We want to not show any aversion to what we see, what we smell. And of course, masks are helpful right now with all of that. But still, we want to be able to get the client to talk about their feelings, what they're experiencing, and what they're thinking, because that is definitely areas that will be therapeutic for your client to be able to talk about those, and what they're anticipating. And of course, you can share the information if if they're going to have a reastomosis, that they just need some time to heal and for things to get back to the pre situation prior before they had this. Okay, the characteristics of the stool, we said it would be liquid bowel fluid. So the lower, so the more colon they keep, the more form their stool will be. But if they have a total colectomy, it's the ileostomy, then it's going to be a lot of liquid bowel movement. And again, you'll be assessing the stool as you would any other stool for any abnormality. It's a good time when you're giving the care to the ostomy care to inquire about their comfort, and of course we're doing that on a routine anyway. But this may be a time where you can really hear more detail from the patient as you're going about your care of the ostomy, and go through the full pain assessment and getting the patient to share with you on that. Think about cultural beliefs and how that might be affect how they normally eat and what they might need to do for dietary modification. One of the things, I think it's asparagus that makes the stew smell really bad. So if they're big asparagus, they will, may find out that there are certain times they might not want to eat it. And things that cause lots of gas, because that kind of blows up the bags as well. But then we teach them how to, you can. I want to say burp the bag. I forget what that's called, but anyway, care of that, because they want it to fit well under their clothing if they're out and about. Consider gerontological principles, and knowing how that the patient, of course, who has elderly, who's having diversions may be more difficult for them, but some of the things that is done when the surgeon is planning on where to place that ostomy, because there is some leeway, but they're looking at the contour of the abdomen and they want to put it to where it'll be easy for the patient to get to, and do their care and do their their appliance changes and so forth. And just different considerations that have to be included there. So this and particularly working long-term care, you may encounter having to do a lot of where the patient may not be able to do any of their appliance changes and skin care and that sort of thing. So I always been vigilant watching that we're not getting leakage, we're not getting any skin breakdown, and immediately reporting that. And that brings me to, there are wound and ostomy care specialties in nursing. And we have a wound care center at the medical center in Tupelo. And this is very helpful in having, specialties to take care of that. Okay, time out just a minute. Okay, so we're looking at assessment, and then we're starting with the oral cavity, and we want to consider things like mastication or chewing and how that's part of the important part of how food is processed. And then another thing that we need to be cognizant and aware of is, does a person have any problem with swallowing? Do they get choked easily? If so, that needs to be addressed, that needs to be reported. Do they have any pain on swallowing, or any reflux after they eat, heartburn, things of that nature? Is there any reason that they are not having a normal amount of intake because of any kind of symptoms like that? Okay, so we can look in the mouth and do an oral assessment. Are there any lesions in the mouth, sores or whatever? What about their teeth? If they have poor dental hygiene? If they're wearing dentures, are they poorly fitting? They worn down? Do they seem to have any problem with adequately chewing their food? Okay. History that we would need to get from this individual was always that last BM, And this can be problematic for people who have problems with cognition, loss of recent memory. I, don't recall when my last bowel movement was. Yeah, I've had one, whatever. But anyway, so getting that information, and you can see the importance of keeping a record of that on a daily basis. Trying to keep a close track on that for our hospitalized patients. And if it's a client who is assisted with that, with the bedpan or the bedside commode, then someone's going to be documented, where it's a licensed nurse or whether it's a unlicensed assistive person. That's going to be documented on their flow charts in their room when they had a BM. But again, looking at the appetite, is there reduction in appetite, any change in their weight, weight loss, significant weight loss? What are routines that are used to promote regular elimination? Are they doing anything like laxatives and enemas and things of that nature? So lots of initial history to get, and particularly when we look at admissions to a facility, we need extensive and maybe even old records pulled or sent over or whatever. Okay, so let's look at the abdomen. When doing the abdominal assessment, we need to look at the shape of the abdomen. We need, again, that full exposure to we can see the abdomen. Is it flat? Is it distended or curved? And is it symmetrical, or is there something greater on one side than the other? So again, protect the patient's modesty as you remove the sheet and lower it down to the hip level, and you pull the gown up to around the diaphragm where you can see the whole abdomen. And let's see. Yeah, if they have an ostomy, you want to look at the condition of that, the color of the stoma. Is there any irritation or skin problems and that sort of thing? Okay, so let's look at page 1206, and this is in your fundamentals book. It's both in the fundamentals, this stool characteristics, which actually gives you like the 7 different types of stools. This is the Bristol stool scale. It's both in the fundamentals book and also your clinical skills book. But there's also a documentation on the normal occurrences of stool, the normal color, the normal odor, the normal consistency, the normal frequency, the normal shape is all right there. So what is a normal frequency of a stool? Well, it can be as much as a couple of times, 2 times a day. It'd be as least as infrequent as 3 times a week. So those are your ranges that are given for normal adult bowel evacuation. So there's lots of variation but anything beyond 2 times a day, we're probably moving toward a loose stool, or something's going on with that, or even a diarrhea. Okay, so let's talk about collection of stool specimens. We would want a clean, dry bedpan. We would need a stool cup. Stool cups also look like denture cups. They're made the same way. And sometimes in times past we've used, but as long as it's clean, doesn't matter. You're going to slap that label on the side of the cup, not on the lid, because once the lid is removed with a label on it, then you don't have a labeled specimen anymore. So it's very important for you, day one, to know, all specimens must have labels, and they must be applied in the correct location. Alrighty. So we're going to get that stool specimen for maybe a stool culture, or we may be getting stool specimens for checking for presence of blood. And you say, well, you can look at it and see there's not any blood. Well, yeah, you could, possibly see blood in the stool, but then there again is minute amounts of blood that may be occurring in the GI tract that may be well hidden in the stool. So we do hemocults, occult, that which is not seen, heme, blood. And Sometimes we can have stool appearance that looks like there may be blood there. It could be someone who is taking iron supplements, someone who's eating a lot of dark green leafy vegetables. Then there's some other things that are mentioned there that typically when I was going to do some stool specimens for hemocults ×3 or hemocults ×6, we tell the patient to hold off on their vitamin C and their aspirin for a few days because those can give false positives on the hemocult. So, be aware of those things. And look at that page, I think it's 1208, that shows, the specimen cup, and it shows the hemocult card. And you can see how that's developed. It's pretty simple, but then it does still have to be carried out according to protocol for it to be accurate. All right, looking at some nursing diagnoses that go with bowel elimination particular problems, and we look at ostomies. We're going to have a disturbed body image. It doesn't matter how comfortable that person is with theirself. I mean, any alteration in loss of limb or loss of disfigurement or anything like that, that nursing diagnosis must be considered, that there could be definitely some disturbance in the body image. And that could be manifested in different ways. It could be through anger, it could be through depression or sadness, or varying ways, or they may be able to take it in stride. Other nursing diagnoses would be if a person has the bowel incontinence, they're not able to control the bowel elimination, or they could have a risk for constipation, diarrhea, acute pain such as with the hemorrhoids or anal fissures and things of that nature. Or they could have a toileting self-care deficit. So lots of different nursing diagnoses that you can explore there in these conditions. All right, some teaching. What would we teach a person to eat a high fiber and bulk forming foods? Well, and low fat. Well, particularly with the presence of constipation, that would be appropriate teaching. Bulk forming food may be good to pull in water of a person with loose stools too, so it's not just for constipation. When we do start our patients on a high fiber diet, we start it low first, just low fiber. We want to start low and go slow, because if you just start with the typical daily dosing of someone who's well acclimated to it, that can be very gas forming and very, very discomforting to start out with. So if we're taking something like psyllium or that would be Metamucil, things of that nature, then we want to start low and go slow, and with lots of fluids. So 2,000 to 3,000 milliliters per day would be very helpful, along with the fiber, to normalize a bowel movement. Exercise is very important, whether it's walking or cycling. But even the patient who is sedentary, who's in the wheelchair, physical therapy and OT therapy and nurses can help the patient, or even activity people can help the patient to move their legs, flex at the hip, flex at the knee, or get assisted in walking and things of that nature. And this is helpful for normalizing bowel movements. Privacy is very important too. We're not real comfortable with people observing us while we're defecating. Squatting position is that would be the best anatomical position to have bowel elimination. And we need to teach patients about skin integrity, clean and dry after the bowel movement. And then, of course, if it is an ostomy, then making sure that liquid stool, which has a lot of digestive enzymes still in it, that is thoroughly washed away, and that we rinse and dry. And then they may need some protective skin protection. Different barriers are being used there. No powders, pat dry, as we said that earlier. Don't rub on that. Okay. So evaluation. So we're always following up with the patient, and asking them various questions on follow-up about changes in their diet, if that is part of what they need to do, or about their fluid intake, if they need to increase that, their activities, what have they been able to do. And this may not be particularly for your, but it might be for your hospitalized patient. And we're monitoring. We're always monitoring. We're reassessing every day. That's the same thing, so we can see that progress there. Okay, and then we want to look at the medications. So medications that we have used to promote defecation, and then some are used to control diarrhea. So laxatives and cathartics soften the stool and promote peristalsis when they are used correctly. But sometimes patients begin to use them every day, and they become laxative dependent. And
from the
some people
bowels
just choose
is a
to abuse
necessary
them.
part.
And this can lead to, for weight loss has been done in the past. It can cause dehydration and depletion of electrolytes, which is a real dangerous thing to do.
From the Maslonian
So,
we see how
cathartics are typically stronger on the large intestine. They come in oral tablets and powders, suppositories as well. A common one that's usually used in the older population is the Dulcolax. It may aid to cause evacuation within 30 minutes.
Components that you will be learning about.
Saline cathartics. This would be like a fleet's saline enema, small volume, and this can increase fluid in the intestinal contents by retention of water by osmotic forces.
Maybe some even earlier days of science where you
help to liquefy the stool and help
the alimentary canal from the mouth to the
other
anus,
things like mag citrate,
all of
which
the
is taken
components
orally.
in between.
Milk of magnesia is another cathartic type laxative.
Let's look at several factors that influence bowel elimination.
They should only be used intermittently, and principally mag citrate, MOM, those kinds of things are used to do a bowel elimination when we're going to have a diagnostic test like a colonoscopy.
That will be required to assist the client
that sort of
promoting
thing.
Normal bowel elimination.
And lubricants would be like a fleet suppository.
Look at nursing assessments that are related
also,
to
we
bowel
use KY
elimination.
jelly.
And
For
select nursing diagnoses appropriate to those
breaking up the impactions and that sort of thing.
And
most of your
then
prepackaged
we want to compare and contrast the medications that are used to treat constipation and those that are used to treat diarrhea. And
enemas
looking at the administration
pre-lubricated, but of course you can always add if it's not
saline cathartics
adequate.
These would be more commonly called enemas.
So different types of enemas.
Some of those are
used.
actually
stimulants.
Had
the lecture
and
on
then
those.
of course we have stool
Opioids are
softeners,
bad
which
for causing constipation
are administered
because they slow
such
down
as Colace
peristalsis.
is administered by mouth, and then those that can
but
be
there
used,
also
such as,
have been opioids have been used to control diarrhea. By that same token, Lomotil is one of the trade names that I can think of right now.
So the alimentary canal from the mouth
avoidance
to the
of using
anus,
those
and,
kinds of things.
What you need to do is review
in more recent years
the process of mastication,
of the danger of
the importance
of actually
of
producing
think about
LES
that,
and totally going
swallowing,
the other way. So we sometimes just
passing
a
through
little
the
fiber diet
esophagus,
will help someone who has
again
had
over the semesters we'll be looking at problems in these structures
their bowel
and how they affect the client.
If that is the cause of the
affect
diarrhea.
care of the client.
Antibiotics definitely.
And going on down, what happens in the stomach,
which may be required
what happens in the small
bowel,
and I'd like to just stop there and mention
which gets the bowel
this is where the greatest
flora
part
out of balance
of nutrition
is a big problem. Like
actually
we talked about
occurs,
the C. diff,
absorption.
which is a big one. Which,
our small bowel is so important in that,
contact
and that
precautions.
There are distinct locations along the small bowel, which is
drugs
much
have also been used
than
for
the large bowel. The absorption takes place and how important that is in the health
These
of
are
the
all
small
found
bowel.
on page 12,
and then,
11,
course,
and
the
12, 16 in your fundamentals
colon,
book.
the large bowel,
so if
which
you,
is
go through and just review those and get familiar and see the pictures here
for
on
bowel
the slide.
elimination.
Get familiar with these different
Reabsorption
things
of water to help maintain hydration as
the
occurring
stimulant
there,
laxatives
and then
the
storing of the
stool
byproducts of
softeners
food
and that sort of thing.
and to what we call the
Okay,
stool or the bowel
thank you
movement,
very much.
until the final process of defecation takes place. Okay, so looking at common problems that occur in each location, and then what are important preventive measures to keep the structures healthy and free of disease. And here's just a couple of diagrams from A and P that help you to think and review from the mouth down to the anus. And here is another cutaway from the just above the stomach, and then down to the anus, where it's highlighted the external anal sphincter and the internal anal sphincter that assist in the containment of stool until the person can get prepared to actually do that in a appropriate location and so forth. Some important terms that we will need to focus on today is peristalsis. This is the motility of the gut. It is a rhythmic contraction throughout the GI tract, and it made me think about that gastrocolic reflex right there, which after eating and the stimulation from the stomach down to the colon with the rhythmic contractions assist in stimulating for defecation, and is a very important tool to utilize. I say a tool, a physiologic process that can be utilized when we're trying to do bowel retraining programs for those who've had an event and lost that normal function. All right, backing back up to peristalsis, paralytic ileus, where GI motility is lost, where there's no peristalsis, then you will hear this term used. It is a medical term. The provider should put this label on, but we can certainly say there is absence of peristalsis if you cannot hear bowel sounds. We'll be talking about that skill of assessment shortly. Melena is blood in the stool. Melanotic stool is a dark color, and typically this bleeding in the GI tract has occurred, fairly high. Could be esophageal, stomach, or the proximal part of the small bowel. The lower the bleed is on down in this lower in the small bowel, more distally, and into the colon, the brighter the bleeding will be. So it has also the factor of time, how long that blood has sat there in the alimentary canal before it is passed, as to the color of it. Because as you know, as when simply having had minor injuries, and immediately following the injury, you will see bright blood, but over the oozing and how it turns into a darker color. And our next term that we want to look at here, steatorrhea, which means fat in the stool. This will appear as a oily, like oil on water in the commode, or could be in the bedpan if that is what has been utilized for the elimination process. You will be able to see like little flat globules. They're present oftentimes, but particularly if it's into the commode and you have the water there. All right, so many factors do influence elimination. Aging, with the decrease in activity, which that is another factor in itself, which could have occurred at any age, but we typically think of the age client who has lost mobility and who is decreased, tends to have more problems with constipation, and also the cellular changes that occur throughout the body, and typically loss of strength would impact the act of motility in the bowel, as well as the actual elimination process. Other factors such as diet, we think about how bulk in the diet tends to promote a more well-formed bowel movement and will stimulate the urge to have a bowel movement. Position during defecation, so the squatting position where there's flexion in the hips and in the lower extremities, that does produce a better position for defecation. So we need to think about that when we place people on a bedpan and they are supine. raise the question, can you elevate the head of the bed? To what degree can you elevate the head of the bed? And so that is always something that you really need to examine, look for an order. There are patients who are postoperative, for instance, post-op hips. Oftentimes, the surgeon gives the order, do not flex the patient to 90%. So obviously they can't be in a full seated position, and certainly that would negate being able to be in a squatting position if we think about that typically. But what degree can you raise to the head of the bed, and how much flexion can we assist the patient with in an unoperative lower extremity? And oftentimes, range of motion exercises may aid a person to be able to follow up and have a bowel movement later. So you want to think about that. Fluid intake, very important. Obviously, the lack of fluid intake would promote a harder stool. And we'll look at some of the pictures of stools that are rated on a scale from 1 to 7 of constipation down to diarrhea. So lack of fluid, definitely. If we don't have fluid in the colon, then that, or it's being excessively reabsorbed due to a lack of intake of fluid, or other things that are causing dehydration. Okay, so many disease conditions can influence elimination. Disease or conditions, rather. So we think about, there are a lot of known bowel diseases such as Crohn's disease, celiac disease, that can affect how well-formed the stool is or how not well-formed it is. Certain infections can cause conditions of diarrhea, and such things as multi-drug use, and particularly multi-antibiotic usage, and in trying to treat infections. And then we have a resulting condition of diarrhea, and you will be learning about those particularly. And psychological factors, this sometimes is in the pediatric age group a bigger problem. The child may tend to hold stool, and sometimes we say they're too busy playing to want to go, and then they end up having accidents, and even on into early preschool age and that sort of thing. So personal habits, and we see sometimes people that are aversive to using public bathrooms in the event that they have the urge to go, and they would tend to hold the bowel movement until they can get to their home or a suitable place for them to eliminate. So certain personal habits can certainly contribute to the development of constipation. Pain with the bowel movement. We have conditions that may, such as hemorrhoids, anal fissures, and things of this nature, that may impact the person with their elimination, and particularly with putting off going to the to eliminate because of the pain. They know that there's going to be pain. So in thinking about that, medications, big problems with sedatives and opioids that slow the gut down and thereby interfere with bowel elimination. It's not unusual, particularly with abdominal surgery and following anesthesia, that the client may develop a sleepy bowel as well. And in that event, sometimes with the actual surgical procedure, there may be so much handling of the intestines that the intestines lose their motility, and we may see this happening. There may be actual abdominal distension. You, as the nurse, go in and are doing your assessment, And when you expose the abdomen, you see that there is a fullness that wasn't there. Maybe when your first assessment, you noticed that the abdomen was flat, and now you see a rounded, distended appearing abdomen. One of the things oftentimes that will cause that distension is simply gas trapping because the bowel is asleep and the normal passage of flatus is not occurring. A tip there is look at the flanks for gaseous distension. The flanks will not fill out. It will be more anterior abdomen that's got the rounded and distended appearance. As opposed to someone who may have a problem with fluid in the abdominal cavity, which that will show up in the flanks as well. All right, let's look at abdominal assessment, and this is very important. The order of assessment techniques, and we just talked about exposing the abdomen. To do abdominal assessment, obviously you're going to have to expose the abdomen. You're going to have to pull back the sheet and pull up the gown if that's what they have on, a pajama top, whatever, and fully have the abdomen exposed, or you cannot assess it. So when you have exposed it, you are now doing inspection, and like we were just talking about, you can see, is it flat? It could be even with someone who's very thin, what we call a scaphoid or a sunken appearance of the abdomen. Or you may be able to see that there's a large amount of abdominal fat. Those are the kinds of things you want to look for. Of course, always looking at the skin. Is there any problems with any area of irritation? Is there bruising? Are there lesions of any kind on the outer abdominal wall? So first of all, inspection. So then the second thing that we do is to use our stethoscope. Oftentimes people are tempted to touch first, but and that's called palpation, or feel for areas of soreness. Particularly somebody said, "Well, I'm hurting here, I'm hurting in my belly, or whatever." And of course, you've always thought about that. Thing is to ask the question, where is the pain? I always find the location of the discomfort and have them to pinpoint it if they can with one finger or two or whatever. But knowing the location of it. But we don't want a hands off first as far exposure, inspect, and then auscultate. The reason for this, we want to know if there is bowel motility there. If you've got a distended abdomen, it's very important to know whether there is motility in the gut. If there's motility in the gut, we should hear the peristaltic sounds, and the little growling sounds, or the little whatever they vary. They can vary depending on what's going on in there. But so place that stethoscope on the abdomen. We divide the abdomen into 4 quadrants, and we listen to each quadrant. There should be 5 to 15 sounds there in a minute, in a minute's time. So, what do you hear? You need to have a quiet environment. Your patient nor the family members or people present need to be talking when you're doing this assessment. Anytime you're auscultating, if you'll kind of just, people start talking, just kind of wave your hand up, or you tell them ahead of time, I need to listen here, so I'm going to need to turn down the TV. We need to turn and be quiet. Have a few quiet minutes while I listen to breath sounds, heart sounds, abdominal sounds. Alrighty. So you want to listen in each of the quadrants, and then you'll be able, if you start in the right lower quadrant and come on around right upper, left upper, and right lower in a systematic approach to listening to the bowel sounds. So what if you don't hear bowel sounds in that right lower quadrant? You listen and you listen. All right, to know that there's absolutely no sounds there, you're going to need to listen to each quadrant for at least 5 minutes. That will be a total 20-minute assessment. So hopefully we don't have to do these things frequently. It's going to be on those people who have no peristalsis, that we're going to have to do that because you'll more quickly be able to hear that you have, bowel sounds much more quickly than that. So then, do your documentation of that. You want to record that. Palpation, and this should be light palpation, should assist you in locating if there is a tender area, because you're not palpating to identify masses or anything like that at this point in your nursing education and as you become an RN. Percussion is done by tapping on the distal joint of the phalanx with the opposite. Typically, we use the middle finger there. Percussion is to determine if there is solid versus a gaseous area. This is pretty much the purvey of the provider and not done commonly by us at all in the direct patient care. This was important tool prior to the development of specialty imaging and that sort of thing, because we could outline the size of, like, the liver, determine that the liver is enlarged or whatever. You could percuss, and once you got over the into the abdomen below the liver, then you would have the area marked on the lower border, and then the higher border, and pretty much determine the size of the liver. Is it enlarged, and do a documentation there. But that is not a functional assessment for you at this point, okay? And pretty much for anybody, since we do have so much technology. Alrighty. Let's see. Abdominal assessment, and then we want to look at common problems, and we've already looked at those on a prior slide, but we'll review those again. What is constipation? This is where the client has had too much water absorbed from the stool, and also it could be due to changes in the diet and lack of bulk in the diet. It says environmental factors are important, and we think about particularly where the person is not keeping well hydrated. It could be due to heat factors and being outdoors, and that's where you're not taking in enough water and fluid. So constipation is development of difficulty in actually being able to eliminate the stool, and then when it is eliminated, the type of stool is little individual hard balls, and this is typically termed constipation. Looking at the term impaction, this is where the client has an urge to defecate, that they are constipated to the point that they cannot exert enough strain or bowel pressure to actually relieve themselves of the constipation. So we'll be looking at how to remove an impaction, and that is a skill that nurses do have to do from time to time. The provider may actually do the digital rectal exam, and we use the short form DRE for digital rectal exam. They're done for other purposes other than defining that there's an impaction there or breaking up the impaction. Rectal exams are used particularly for the male client in determining if there is prostatic enlargement or if there's prostatic inflammation. Also, palpating for things like blockages in the lower bowel that are just in the rectal area, as far as provider doing that. But the provider may say check for an impaction and remove if present. Now this is a skill that must be done very carefully because it's traumatic, first of all, to have an impaction, and doubly traumatic to have it digitally removed. So the the licensed nurse, cannot delegate that to an unlicensed assistive person. The nurse can have the assistive personnel, nurses' aides, and attendants, whatever, to gather the equipment and assist with the preparation, positioning the patient, assist with cleaning up the patient following the removal of the impaction. So it's always good if you can work that in before giving the bed bath. If most of these clients would be having to have a bed bath that they're having, not necessarily all, because I've seen one just popped in my mind of a lady who had birthed a baby and had gone home and had not had a bowel movement and had to come into the ER. And she had had a episiotomy, so we had to actually call her OBGYN, and he actually came in and broke up the impaction. So there's kind of a wide variation of situations you can get into with this kind of thing. But this is a common thing that happens, can happen quite easily. And so, that being said, this is why we stay on top of bowel movements, and we ask the patient daily, and we watch just think about the long-term care patient where we got to, watch and are they having a bowel movement? And sometimes it's hard to keep up with your ambulatory patients, particularly those who are ambulatory, have the bowel movements and then forget about it, and we're unaware when they last had a bowel movement for sure. And because a lot of this, as we say, are reported, and we always want to ask them about the character of the stool. Does it range from watery up to that constipated stool? Or where is it, getting a description of it and the color and so forth. And back to the removal of the impaction. So gathering the equipment, what are you going to need to remove an impaction? Well, obviously you want well-fitted gloves, and typically we kind of double glove for protection there. And I think you can easily see why you would not want any jewelry on, and why you would want your nails to be short, because you certainly don't want them cutting through your glove. Lubricant, and you may want several packets of lubricant. You would want to make sure there's adequate tissue in the room. You want to make sure that you have a bedpan, a receptacle to receive the stool as it is removed. That, I suppose could be placed on a blue pad, but we traditionally have used the bedpan. You would want a water permeable, like a disposable underpad under the patient. It kind of gets messy. And let's see, gloves, lubricant, the receptacle, and your padding, your underpadding, and the toilet tissue, and then of course plenty of bath cloths and stuff to assist the patient afterward in the cleanup. So the nurse would don the gloves, position the patient, lubricate the glove, and just checking for the impaction, very gently. And if the patient can bear down as you insert your index finger, then that makes insertion of the finger easier if they kind of give a little bear down movement. And then oftentimes with impaction, you're going to feel the stool right away. It's going to be right down there, and what they've termed a higher impaction, it can be above the internal sphincter in the rectum. So full insertion of the finger if you don't immediately feel it, and then identifying that is indeed stool that is in the passageway and it's not coming out. So as you read the skill, it tells you that you gently go around the stool very gently, and here you're dispersing the lubricant, um, and um, and then hopefully there will be a place where you can kind of catch a hold of a corner of the stool, and then it's simply a breaking off of small pieces, and then pulling that gently down, to the anal passageway. So that this might take some time to remove the impaction. We may follow up with, may have an order for, a different lubricant, like the Fleet's oil retention, or it could be a Fleet's, depending on the patient's condition, just a normal saline to help wash it out, the area, and help stimulate peristalsis. Okay. So what is diarrhea? Diarrhea is a watery bowel movement, liquid bowel movement, and typically before we pronounce the presence of diarrhea, we're looking for, not just one stool that's watery, not just two, but typically somewhere around four stools in a 24-hour period that would characterize the presence of diarrhea. So sometimes that can happen quite fast with the rip-roaring viral thing, or even with this development of a diarrhea secondary to antibiotic therapy. Okay, what is incontinence? Incontinence is the inability to retain the bowel movement, where there's denervation of the sphincters, and this could be from the local trauma, or it could be from the central nervous system where incontinence. It could be from a spinal injury where the patient is unable to retain their urine or retain their bowel movement until they can find the acceptable location to eliminate. Sometimes it can be like a spillover incontinence where there is an impaction that's present, but liquid stool kind of gets around it, and they may be developing temporary type of incontinence there. Okay, flatulence is the presence of lots of air in the bowel, and the patient may be distended, or they may be passing gas fairly well. So there's different conditions. It could be related to food, or it could be related to some internal condition that's producing excessive gas. Hemorrhoids are distended vessels or veins in the anal rectal region, and they can be internal or they can be external, and they're viewed as can vary in color from just a fleshly color, or they can be a purplish color, depending on if they're entrapment of blood in that hemorrhoid, and it's protruded out, and difficult to reduce those. So these develop from intra-abdominal pressure, such as pregnancy, such as ascites, which is free fluid in the abdomen, or abdominal obesity and straining at stools. So different contributors to the development of hemorrhoids. So hemorrhoids are often treated with a preparation H or HC, which stands for hydrocortisone, which tends to help to shrink down the swelling and make them more reducible. And at times, when hemorrhoids can be so bad that they are surgically excised or removed. Ileus is another term for the paralytic ileus. So we simply don't see the paralytic in front of it, but it means the same thing. Okay. So here is a rectal tube. We've had flatus tubes for many years for people who were unable to pass gas due to decreased gut motility or lack of peristalsis, particularly following surgery, and might tend to get into quite a bit of discomfort from the gaseous distension of their abdomen. But this particular rectal tube, which uh, obviously would allow the passage of gas, but also this device in recent years has been developed and used for diarrhea, particularly when the patient is in a acute care situation. And I've seen these more often used in intensive care areas where the patient was continuously having a diarrheal stool. This rectal tube can be placed. It does have a balloon on it, like the Foley catheters, and so we have to be careful with it, because anytime we're blowing up balloons inside a patient, whether it's in the bladder, which is we always want to avoid blowing one up in the urethra. We'll be talking to you about that later on. But other tubes that we place inside a patient that have balloons on it, that we have concerns and monitors to make sure the balloon doesn't cause pressure and thereby tissue ischemia. So this is also true, but we can contain, a lot of just continuous fecal incontinence that's going to macerate the skin and cause skin breakdown and to a contained system. And so, you can definitely anticipate seeing those from time to time. So we just want to be sure that we don't overfill that balloon that's on the tube. Okay, so we want to talk a bit about diversions, bowel diversions, and at times there are lesions in the gut, and it could be the colon or it could be even higher, that require that we divert the bowel movement. And so anytime there's a bowel resection, and well, for instance, even if there's going to be a reconnect, we call that a reanastomosis or anastomosis of hooking back up the ends that were on each side of that lesion, whether it's a malignant thing or if it was just an obstruction, but for whatever reason. So oftentimes the patient is going to have an ostomy, and that means bringing the gut out to the skin and making a diversion for the bowel elimination. So surgical opening through the abdominal wall for passage of BM, colostomy. It could be an ileostomy, so it depends on what portion of the gut is brought out. So for instance, if we had a client who has all of the colon removed because of, so it could be a trauma thing, or it could be some other loss of functioning of that bowel, and so the client loses, say, the whole colon. Well, they will have an ileostomy, because the ileum, remember, is the distal portion of the small bowel which joins the large bowel in the right lower quadrant there in the cecal area, where the location of the appendix is. So creating a surgical opening, of course, they have to open the abdomen. And when I say open, there's a lot of things that are done robotically now, so there's small openings, not the big opening. And the portion of the bowel that's brought out to eliminate into a bag. And we'll talk a little bit more about that. So there are different types. There are those that are determined, hey, we can hook this back up once they get over this acute phase. We get healing down there, particularly where they make pouches and where the patient can be continent, and then they go back and reconnect later, and that's called an anastomosis or reanastomosis. Okay, so where were we? Got that one here. Okay, so nursing considerations. So in addition to our assessments, it's very important in our communication how we respond to the patient, because we want to promote and maintain their self-esteem. And you can just imagine what is going on with a person who has had this procedure done, and they now have an ostomy, and that is like other disfiguring types of surgery. You say loss of a breast, loss of a limb, any kind of uh, alteration in the body. We have to acquaint with the body, identify with ourselves there. So how nurses speak about the condition, both verbally and non-verbally, how we communicate non-verbally. So let's look at non-verbally. You're caring for this client, and you are cleaning around that ostomy site, which initially after surgery typically is cleansed with normal saline. And then as we get some healing, we can simply wash it with soap and water, rinse it good, pat it dry. Then we replace the device, which has an adhesive on it. And there's in our kits that we get nowadays a device that looks like a sheet of paper. It's got different size holes on it. You find the right size hole, fit it over it, and then you cut trim your adhesive pad on your device to fit over that. So you simply trace it on that, and then place it on that. It's pretty well self-explanatory, but you will need to handle it and get used to it, of course, like all other things. But in the way that we interact with the patient during this process of cleaning and reapplying our appliances, teaching the patient how to do it, they're going to do it for a while, probably before they come back and get their rehook up, if they're able to get that. Then the expression on your face must not have any appearance of aversion. So if you look for the lining in the silver cloud about having to wear a mask, you see the advantages of having on a mask while you're learning this. So, but anyway, underneath that mask, work on what if I didn't have on a mask? What would my expression be? So, and we have things that we can put on our mask, and we've done this in surgery forever. Peppermint oil, just the tip of that on the, around the nasal area where you won't even smell the fecal smell in the room, which the fecal smell is going to be more prominent. The effluent, the bowel effluent that's collecting that bag is going to be more pungent, if you will, than a typical, what we normally say, the normal smell of a bowel movement, which everybody's smelled one, so you know how that goes. So with this is one thing you just kind of have to take in stride. Then the verbal communication, you want to get your patient to talk about their feelings, how they're feeling about this, what they're thinking, and so forth. And then, you don't want to just have a ready commercial to give them about how this, that, and the other, but listening to your patient. And that's how you are showing concern, and how you're showing, that you are there to support them. Okay, so like we said, the characteristics of the bowel effluent are going to be more liquid, because we have particularly the higher in the colon that the ostomy is, the less reabsorption of fluid that it's going to be. So a very low, where the client has most of their colon, it's going to be more. In fact, there have been some who have had to have irrigations to pass it, just like they were getting constipated. So you can see how you got to assess. It's not a one shoe size that fits all. Again. All right, so we're going to be doing pain assessment. You have your pain assessment lecture, which tells you to always, when the patient says, I'm hurting and I need something for pain, your first go-to is to pinpoint the location, like we talked about a while ago. Have them to identify the specific area that they're hurting, because you will document that. The location, when did it start? How long has it been going on? So the onset of the pain, and then asking them about the character of the pain. What is it like? Oftentimes with abdominal pain, it's a cramping pain, but it doesn't have to always be cramping. They can have a different type of pain, because there's other structures in the abdomen where the source of the pain could be pathology. There could be causing such as a ripping feeling, or a sharp stabbing feeling in there, so intermittent, it's not constant. Even cramping is not constant. So getting the patient to describe what's going on with them. Then, of course, you're going to use that for adults who can give you a numeric reference on their pain for the intensity of it, and we use 0 to 10. 0's no pain, 10's the worst pain you can imagine, and we try to use that parameter because a lot of people will want to step outside of it and say, well, it's worse than a 10, but again, we're using the parameter 10's the worst you can imagine. So doing your documentation there, doing your response. What did you do about that pain? Well, right now you're not administering IV pain medicine. You can't do that for a while. So we can give an oral pain medicine, but on abdomen, a lot of times they may not be. If they're in acute pain, we're probably holding anything by mouth, and they would be getting it IV. But anyway, reporting that pain. Make sure and document your reporting of that pain. That should be on your nurse's notes at the end of your clinical, where you have done this assessment. Assess any kind of cultural impact that may be riding there and how it affects the client's diet. And it just be their their eating patterns, the things they just don't eat, and that sort of thing. I always like to emphasize the importance of, healthy nutrition when you're getting this as well. It's a good opportunity there. And then again, consider the gerontologic. We talked about that earlier. And okay, I've gone backwards here. Here we go. All right. So when we're looking at the outcome of, let me get back to that. Of bowel elimination, we have to take into account those things that have happened up above it. Again, chewing. So if the person has good dentition, healthy teeth, they don't have problems with loss of dentition, or what about if they do have and they have dentures? How well fitting? How are they able to chew? What about swallowing? Are they having any swallowing problems? Is there anything that's interfering with their intake of food? So all those things that are occurring in the upper alimentary canal. Have they been able to take in normal amounts of food and fluids recently? Any of those factors. And like on your diet sheet that your 24-hour recall, what is normal for that individual? That's why you're doing that, to determine what is their baseline, what do they generally do. So this not only affects the elimination, but also affects their nutrition. So you've already got that. All right. Yeah, I think we pretty well have covered that. Other things in your assessment, looking in the mouth, do they have any kind of lesions in their mouths? Do they have poor dental hygiene? We mentioned the poor fitting dentures or lack thereof. So other factors. So we need to get as much as we can information that we can know what all may be impacting on their bowel elimination. Okay. So on page 1206, we do have, and this is in the, it's in both your fundamentals. This is the fundamentals book, 1206. It's the normal and abnormal fecal characteristics, and also has things like the looking at the, giving you the parameters for looking and assessing the color, the odor, consistency, and the shape and all of that. But 1206 is in the fundamentals text, but this is also in the clinical skills as well. You have it in both books. Okay, so you want to look at that and get familiar with those. Still, again, the importance of actually, documenting that shape and the frequency and so forth, and not just using some number. Some places may use the numbers that if they're using it on a flow sheet to particularly a GI unit. All right, so let's talk about the consideration of obtaining stool specimens. So we might be obtaining a stool specimen for a hemocult, and that is for the presence of hemoglobin that you can't see with the naked eye, or blood that you can't see with the naked eye. That's occult or hidden, that which is hidden. That's why it's called a hemoccult. It's also known as stew for guaiac, Guaiac. Okay, so we may simply catch that in a bedpan, if they are not able to get out of bed and go to the commode. If they're able to go to the commode, we can take that device called the hat that we used to place in a urine and place in a commode on the anterior part. We can you want to get a new one. Well, don't have to just have it clean and dry, so it can be rinsed and so forth. But anyway, and if they're having a bowel movement, we can catch that for a stool specimen. And it can be then placed in a stool cup and sent to the lab. Okay, remember all specimens are labeled. It should be labeled on the side of the cup part, not on the lid. Not on the lid. They take off the lid. You have a specimen label up there with the patient's name on the top. What if that lid gets lost and you don't know whose specimen it is? So it should be on the cup portion. And then the lab person can take a specimen. There's a picture in your book of how we check for hemocults, how we develop those, or stews for guaiac. So if you look at that in the clinics, oftentimes you will get a checkoff on that, and you will be able to do that particular test as well. Okay, now what if we need to collect a stool for a culture? So it should be collected in a clean, dry bed pan. We don't have sterile bed pans to collect. Everything else, we collect is under sterile conditions. We collect stool, urine. It's unless we do the clean catch midstream, that would be the only other way that we do cultures on those. But in and out catheters to obtain urine for, that's done under sterile conditions. We use sterile swabs to swab nares and throats and that sort of thing for culturing those areas. But anyway, so the same process of collecting a stool specimen. Just be aware that you have a clean dry bed pan, and then it's we use like tongue blades, or there may be just little stool that come in the stool packet to do a transfer of a sample into the stool cup. Okay. If we're doing like an annual screening for hemocults or stool for guaiacs, then we get 3 separate stool specimens, and those can be put directly on the card, and we've even taught patients how to do that at home for the annual stool screening. Be aware that there are things that can confound this test, though. Vitamin C is one thing. We discourage meat that is not fully cooked. So you think about people who eat their steaks and they're not well done, then this could actually confound the test, and that we could actually have a positive from that eating that meat. And some other vegetables that can also confound it, such as turnips and horseradish. I'm not sure what substance are present there. Iron and salicylates, well, iron can give you that false color. I don't know that it would cause the actual test, but anyway, being aware that we'll hold off on aspirin and things like that for a couple of days while we're doing that annual screening. Okay, some nursing and diagnoses that are involved with bowel elimination, and we've already talked about how if it is a bowel diversion, that this can certainly impact the body image. So we may be able to identify that nursing diagnosis. Bowel incontinence, obviously for those who can't maintain continence and have accidents and so forth. Risk for constipation for the client who is bedfast, who has decreased mobility, who has decreased intake of fluid, who has particular diet habits that promote constipation with the things that they ingest and lack of fiber in their diet. Diarrhea, and that would be, as we determined earlier, the watery stool, the number of stools, and that sort of thing. Acute pain with abdomen in particular will occur with like the ileus and abdominal distension. And then other diagnoses, what about toileting and they're not able to do it alone? They have a self-care deficit, they need assistance. So that would show up there in those plans. Okay, so in our teaching, and we're ever more doing that, as soon as we admit a patient, we begin our plans for discharge. Now, I might not, with an acute pain patient, abdominal distension, ileus, for whatever reason. I know I need to teach this probably at some point, so I may be planning my teaching, so I am preparing for discharge, but we have to, look at the teachable moments, and that's not when somebody's in acute pain. Does that make sense? Okay. Importance of fluid intake each day to maintain adequate hydration and thereby to promote adequate fluid for stools to be within the normal range of consistency. Importance of exercise, and of course we know that there are patients who are non-ambulatory, but can we do passive range of motion, hip flexion, lower extremity flexion at the knee, repetitive, those kind of things, so that would assist the patient in having some activity that will stimulate bowel activity. Privacy is important. We know the position we can get them in, the best position we can get them in for elimination. And always talking to them about skin integrity, particularly around their appliances, and if they have fecal incontinence, that skin protection, cleansing, and frequent assessment for that. All right, evaluation. So we want to talk to the client, ask them about in follow-up changes in their diet, fluid intake, activities, and skin. This is labeled evaluation, but it's also assessment. So that is always ongoing. We're asking a lot of the same questions and maybe in a different manner, in a follow-up manner, but the same types of questions we're asking. We want to look at our medications that are used in assisting with bowel elimination. If it's constipation, we're using cathartics and stool softeners and bulk formers and lubricants. Opioids, their own, we do, and for the ones that are looking at those lower things where opioids, antibiotics, and anticoagulants, we're thinking more in order of the diarrheal elimination of a watery stool. So we had things like Lomodal that actually was an opioid. So we know that opioids will produce constipation as well. So or it puts the bowel to sleep, reduces peristalsis. As we have mentioned earlier in this presentation, we talked about antibiotics and particularly having to use lots of antibiotics to treat infections, how we get into situations where the bowel flora, the antibiotics will not only take out the good or take out the bad, but it will also take out the good in a lot of situations. So we get that imbalance and we don't have our normal flora in the GI tract. So then that promotes for the development of abnormal watery stools. Anticholinergic drugs, so that's on page 1211 and 1216. This is in the fundamentals book, I believe. The type of medications that are used in treating cramping and diarrhea, anticholinergics to reduce that spasm kind of thing. We're very careful with those because we don't want to, the patient, best practices have determined that using a lot of those type of medications may actually predispose the patient into a loss of motility. So we ranging from one thing back to the other side. So we also have found, fiber, bulk forming things like fiber in the diet also can be very helpful for a client who may be having diarrhea. And people would, oh no, I don't need the fiber. I've already got diarrhea. But the fiber will actually soak up a lot of fluid and help to form help the stool to become more formed. So that is something that may be beneficial, particularly in your ambulatory clients. Um, one thing about adding fiber to the diet, you want to start low and go slow, because you can actually promote a very gassy situation by implementing a full dose of a fiber. Okay, so I believe that is our last slide. So you already have your outline guide that goes